Good morning, good afternoon, or good evening, depending on when you're watching this. This is Chris Frothingham, and I would like to thank my dear sister Stacy Pierce-Talsma, whose lecture I adapted for this. So what we'll go over today is just a brief review of some of the sacral anatomy, and primarily as it applies to palpation and diagnosis. We'll talk about the motions of the sacrum and what types of somatic dysfunction we see in the sacrum, and then we'll talk about some of the special tests that we use to assess the sacrum and how we actually diagnose and name sacral somatic dysfunction. The objectives for this are listed here, and we will cover all these today. And this is just a nice little quote from Foundations, and the point I think of this is to be aware of the fact that the sacrum does not act alone, and if there's dysfunction in it, it will affect not only the sacrum itself and the pelvis, but also the entire spine, the lower extremities, the craniosacral mechanism, thoracoabdominal and urogenital diaphragms, and I would add the upper extremities as well. So it really will have a very profound impact on almost any other area in the body. So if we look at some of the anatomy just basically here, and as far as some of the landmarks that we're going to need to think about, we'll be looking at L5, the spinous process, and the transverse processes. Dynamics of L5 relate directly to sacral mechanics, as you'll see. We'll be looking at and using the PSIS in part of our diagnostic process. We'll be assessing the sacral sulci and the infralateral angles, or ILAs. Just a couple of morphologic points to be aware of in the sacrum. There are two developmental anomalies that can occur. One is lumbarization, the other is sacralization. As you can see in this slide on the left here, there is not full fusion here between S1 and S2, and it looks like there's more of a facet joint here, and this almost maybe looks more like a fracture, so it may have been more fused over there originally, but you can have a non-union of S1 to S2, so this S1 segment behaves more like a lumbar segment. Conversely, with sacralization, L5 in this case actually fuses to S1, and it's nearly complete. You can see there's just a tiny little intervertebral space left in there, but essentially this has all become fused. So L5 functions more like an upper sacral segment. So those are just some things to be aware of. They're not that common, but you may find them. And you may also find this either lumbarization or sacralization occurring unilaterally, which will also have a significant effect on mechanics because it produces asymmetry. Now I want to just discuss quickly the concept of form and force closure. Form closure has to do with the shape of the joint in question. And as you will see, the sacroiliac joint has a very unique shape. And so schematically, it's represented here with this clear right angle. And so clearly this block here that represents the sacrum fits in these notches, which prevents the sacrum from dropping through here. So that would be an example of form closure. If we look over here in the middle, there's nothing about the shape of this relationship that is holding it in place, but rather the force or tension across the joint that maintains its stability. So this would be an example of force closure. If you have the two working in concert, then you get something that, again, schematically looks more like this. There's some element of the shape of the anatomy here that provides stability, as well as force and tension across the joint that maintains the integrity of the joint. So here, if we look at form closure again, we're talking about this shape of the sacrum. Now this is a transverse view through the pelvis, so you have innominate out here and out here on the most lateral parts, and then the sacrum is in here in the middle. And we're looking at the SI joint right through here on either side. So that unique shape helps contribute to the form closure. And again, you can see here from a lateral view this very unique shape, and you can see that there's some concavity and convexity to it. So those two, the sacral part and the ilial part are going to fit together in a particular way to be relatively stable. But then if we look at all the different myofascial components that cross from sacrum to innominate or extremity or back, we start to see some of the structures that will supply that compressive force through the joint and help support it. So some of the big things mentioned here are the gluteal muscles, piriformis and latissimus dorsi, which is one of the reasons I included upper extremity in the areas impacted by the sacrum. But you can see that coming in through the thoracolumbar and lumbosacral fascia into here. If we look specifically at piriformis as an example, you can see the piriformis right here and its distal attachment on the greater trochanter, and it comes and crosses the sacroiliac joint. Now this is a posterior view on the left. If we look on the right, here you can see the phantom piriformis behind the innominate, and then it comes up and attaches on the anterior surface of the sacrum. And just one thing to think, will sort of push your thought process forward a little bit, or fast forward. If you look at where this attaches here on the sacrum, and think about the piriformis, if we go back over this posterior view, in this neutral position, when the piriformis contracts, it's going to externally rotate the femur. If we flex the hip so that now the femur is going out this way, and you contract the piriformis, it's going to abduct or abduct. So as you'll see when we're talking about treatment of some of the torsions, specifically the backward torsions, you'll be using the extremity on the affected side with the hip flexed and resist the patient's abduction, which is going to fix this end and lead to motion happening here, and it will help pull the sacrum forward again. So that's why we use one leg to isolate the piriformis in part to help pull the sacrum anterior again when it is stuck posterior. But this is again an example of one of the structures that contributes to forced closure. And then if we look at some of the ligaments here quickly on this anterior view, you have the iliolumbar ligaments here on either side coming off the transverse process, and then you have the anterior sacroiliac ligaments here on either side going across the joint and contributing to that forced closure. And then if we look at the posterior view, here again you can see that iliolumbar ligament there a little bit, the posterior sacroiliac ligament on either side here running across the joint, and then there's the long dorsal sacroiliac ligaments here coming off of PSIS, and they blend into the sacrotuberous and the sacrospinous ligaments. So you can just see the sacrospinous ligament ducking out here behind the sacrotuberous on either side. And those all help support the sacrum. And these two ligaments here, the sacrospinous and the sacrotuberous ligament, help limit anterior motion of the sacrum. As you will see, when the base of the sacrum here moves anterior, the apex of the sacrum moves posterior. And here, as this tries to move away from you, these ligaments here, the sacrospinous and the sacrotuberous, are going to resist that. And then we have the various structures, muscular structures that make up the pelvic floor and the pelvic diaphragm that, as you can see, interact with the sacrum and again contribute to that forced closure and provide stability for the sacroiliac joint. And I would be remiss if I did not mention the autonomic considerations. So as we've been looking through the rest of the spinal column, we've been thinking about primarily the sympathetic supply in the thorax and the lumbar region to various organs. And now down in the sacrum, we've got parasympathetic considerations. And we're really looking at the pelvic organs, the more distal portion of the GI tract, and kidneys generally are considered to have some pelvic splanchnic input. Certainly the ureters do. So when you're assessing somebody's sacrum and noting dysfunction there, you would want to make sure you have in your mind some consideration of these various organs that could be impacted by sacral dysfunction, or that could be secondarily causing the sacral dysfunction in the form of a viscerosomatic reflex. So you can either have the viscerosomatic reflex, in which case you need to be looking further into what visceral conditions may be going on, or you can have a primary problem with the sacrum, but that may be causing a somatovisceral reflex. So you'd want to be asking your patients about lower GI review of systems and urogenital review of systems. The other thing to think about as well, potentially, is if you have a primary sacral dysfunction and it's affecting these organs, there may then be a reflex back into the lower thorax and upper lumbar region where the sympathetic supply derives for these organs. So you could find somatic dysfunction in this area as well, which would be another jump down the chain. So these relationships are important to bear in mind as you're evaluating your patients in any region. When we talk about the different types of motion in the sacrum, these are the things we'll primarily be talking about. So there's postural motion, which refers to, as far as the sacrum goes, which refers to how the sacrum moves when you change positions. For example, when you go from standing to seated or seated to standing. Respiratory motion is going to refer to the anterior and posterior motion of the sacral base as we breathe. And so when we inhale, the spinal curves flatten and the base of the sacrum moves posterior. As we exhale, the AP curves of the spine accentuate and the sacral base moves anterior. When we talk about inherent motion, here we're talking about nutation and counternutation, or flexion and extension, respectively. So in nutation or flexion, the base of the sacrum moves anterior or nods forward. With counternutation or extension, there's posterior motion of the sacral base. And then when we look at dynamic motion of the sacrum, that's going to be a more complex type of motion, such as occurs when we're walking. And these motions occur around various axes. So we'll look at 3 transverse axes, superior, middle, and inferior. And by and large, we consider the superior axis to be at roughly the level of S2, but I'll speak to that a little more in a moment. But that's generally where we see the respiratory motion and inherent motion relative to the craniosacral mechanism. The middle transverse axis is where we see the postural motion, so changes with standing versus sitting. And then the inferior axis is the axis on which the innominate rotates relative to the sacrum. Now, in terms of exactly where these transverse axes occur anatomically, it was thought for some time that the superior axis was at S2, the middle at S3, and the inferior at S4. But it seems more likely that, in fact, the exact location of the axis of rotation for any of these types of motion is, in fact, a more dynamic thing. So where the axis occurs may vary and depend on several factors. So it is now not thought to necessarily be always at a particular sacral level. So that's the transverse axes. And then we'll also look at 2 oblique axes, a right and left. And these are named for the superior pole of the axis. And you'll see some illustrations of this coming up. So this is roughly where we would see the 3 transverse axes. And if we look at how motion occurs around a transverse axis, the red dot could represent any of the 3 transverse axes. And as you can see, with this motion, as the sacral base moves anterior, the apex moves posterior, and vice versa. So over here on the left, this would represent sacral flexion or nutation because the sacral base is coming forward. And this would be counter nutation here on the right, with the sacral base moving posterior and the apex moving anterior. And it's important to then be aware also of the relationship of L5 to the sacral base. So here we're looking at the motion of the sacrum around a transverse axis, but as this moves forward into flexion, L5 is going to extend. So you can imagine the cogs of a wheel. If this wheel is going clockwise here, the sacrum, the L5 is going to have to go counterclockwise into extension. And the opposite is so here. As the sacrum goes into extension, the L5 will go into flexion. And here again are the oblique axes. Again, they're named for the superior pole, so this axis here, running obliquely with the more superior end of it on the left side, would be the left oblique axis. This one here would be the right oblique axis. With movement around an oblique axis, there will not only be an element of flexion and extension with the sacral, one side of the sacral base moving anterior and posterior, but there is also rotation. So there you can see initially flexion, extension, then some rotation. This is an awful lot of motion awfully fast, and I think represents shaking your moneymaker. So if we consider the relationship of L5 to the sacrum, as we saw in one of the slides just a moment ago, we have a relationship between L5 and the sacrum that is L5 extending with sacral flexion and L5 flexing with sacral extension. The other consideration is that the lumbar spine will side bend in response to sacral movement as well. So as the sacrum rotates in one direction, the lumbar spine will rotate in the opposite direction and therefore side bend in the same direction as the sacral rotation. And if we look at sacroiliac motion, this is a joint that has synovial fluid and has features that, as we looked at before, contribute to the form closure. Elements such as the general L shape of the joint and the concavity and convexity of the surfaces. These will contribute to that motion and stability. And as we mentioned before, sacrotuberous and to some extent the sacrospinous ligaments will help prevent sacral flexion, and the long dorsal ligament, seen here, will help prevent excessive extension of the sacrum. And this is just a nice illustration of side view of the sacral part of the SI joint, and you can see that roughly L-shaped morphology of the joint. And so as there is inferior motion here, there's posterior motion here during nutation or flexion. During counternutation or extension, this posterior part of the sacrum is going to move anterior, and this will move superior around the axis here. So if we try to clarify this schematically, if we look here at a different view now of the ilial component of the SI joint, and we say, sort of exaggerate that L-shaped form. And if we imagine that these two black lines are rails, and here's the sacrum sitting across it, or sitting across the articulation, and imagine that the sacrum moves on these two wheels, on the rails. If we apply an inferior force through one SI joint or the other on the sacrum, so we're going to try to move the sacrum inferiorly across this joint or shear it, you can see that this wheel is going to roll inferior down this vertical rail, and this wheel will roll posterior down this horizontal rail. And the outcome will be that the sacrum moves into flexion, so that the base of the sacrum up here has dropped inferior and anterior. The apex of the sacrum has gone superior and posterior. And if we look at the motion here, at the very beginning, you can see the lumbar sections extend while the sacral base flexes, and then the sacrum continues to dance around under the lumbar. So this part, last part, isn't as helpful, but the initial motion is helpful. And now we look over on the other one, we see lumbar flexion with sacral extension. So that's the type of relationship we have going on with L5 and the sacrum. And in terms of talking about convention of naming of sacral motion, as with the spinal segments, we talk about the position of the sacrum relative to a point on the anterior superior edge of the sacrum. So we're going to be talking about where this aspect of the sacrum is looking. So this can move anterior or posterior, and it can turn to look to the left or look to the right on this anterior view. So here's some of the ways that we help assess the sacrum and piece together our diagnosis. We'll use the seated flexion test, the spring test, and then we will look at landmark palpation, particularly of the ILAs and the sacral sulci. The seated flexion test is done to suggest sacral dysfunction in regard to the SI joint. So in the seated flexion test, as you will see in the OMM videos, you have your patient seated, and they slowly bend forward, starting at their upper spine and rolling down. And as the lumbar spine goes into flexion, the sacrum should counternutate, as we saw earlier. As the sacrum reaches the end of its range of motion in counternutation, it will begin to move the pelvis, and the PSISEs will be carried superior. And that is what we'll be looking for on each side, and we'll be comparing the right and left. The seated flexion test is positive when the PSIS on one side moves either before the other side or farther than the other side during forward flexion. So in terms of what we learn from the seated flexion will tell us what side, which SI joint is dysfunctional. So again, the side, the PSIS that moves first or farthest, is the side that is positive. So that'll tell us which side is dysfunctional. Depending on the type of dysfunction we're matching it up with, in a unilateral sacral dysfunction, it will again tell you which side of the sacrum, right or left, is the dysfunctional side. In a bilateral sacral dysfunction, the seated flexion test will be equivocal or will appear negative. In torsions, and we'll talk about what all these are in just a moment, the seated flexion test will be positive on the side, again, that is dysfunctional, and it will be opposite the side of the axis that we use to name it and around which the dysfunction happens. So we'll talk about that in a little more detail here and clarify that. So again, when we're looking at these landmarks here, in the purple dots here, you'll see the sacral sulci, and the red dots are the ILAs. And the sulcus will give us information about the position of the base of the sacrum. The ILAs will give us information about the position of the apex of the sacrum. The spring test we use to evaluate motion at the lumbosacral junction. To do this test, you'll palpate with one hand at the base of the sacrum and ask your patient to prop him or herself up on elbows, which will extend the lumbar spine and should induce flexion at the sacral base or anterior motion at the sacral base. If it is able to move forward, that is, and you apply a little bit of force there, you will feel that there's some spring there, and so finding that there is spring is normal. Therefore, it is a negative spring test. If, however, the sacral base is stuck posterior and is not able to move anterior in flexion with lumbar extension, then you will note a stiffness or rigidity to that region, which would represent a positive spring test. So this is giving us information about the relative position of the sacral base, either anterior or posterior, or its ability to go in an anterior direction. So this again just illustrates the direction of the gentle force you're applying at the lumbosacral junction to see if you can get motion there. And this would be another illustration of it. So here the physician has her hand across the lumbosacral junction and is putting some gentle force down toward the table while her patient is propped up on his elbows to produce lumbar extension and sacral flexion. If there is no spring here and it's rigid and stiff, then that's a positive spring test. And this can be very confusing and takes a little getting used to. If there is spring, it's a negative spring test. If there's not spring, it's a positive spring test. And takes a little getting used to. If there is spring, it's a negative spring test. If there's not spring, it's a positive spring test. So how do we use these to diagnose? For torsions, there are forward torsions and backward torsions, and either of those has two options. And we'll talk about the naming convention of those in a moment. There are unilateral sacral dysfunctions that are either flexed or extended, and bilateral sacral dysfunctions which are flexed or extended. And we'll go into details in those as well. An important point is the distinction of physiologic versus non-physiologic motion. And as you can see over here on the left, all of these represent physiologic motion except posterior torsions or backward torsions. So where is the dysfunction with each of these different kinds of somatic dysfunction? In torsions, both forward and backward torsions, as well as the bilateral flexion and extension, the primary dysfunction is occurring at the lumbosacral junction. So it's the relationship of L5 and S1 where the primary issue lies. In unilateral flexions and extensions, the primary issue actually lies at the sacroiliac joint. So let's talk a little bit about the sacral torsions. Again here, we're talking about an issue at L5 and S1, and part of the relationship between L5 and S1 is not only that sacral flexion is paired with lumbar extension. Normally, when the sacrum rotates in one direction, L5 will rotate in the opposite direction. The sacral motion in a torsion occurs around one of the oblique axes. In an anterior or forward torsion, one side of the sacrum can only move anterior and is not able to move posterior. And conversely, with a posterior torsion, there's one side that is unable to move anterior. Both sides can move posterior in a posterior torsion, but the side that is restricted is not able to move anterior. So with the forward torsions, your diagnosis will be right on right or left on left. The two directions are the same. With the posterior or backward torsion, there will be opposite. You'll either have a right on left or left on right, and we'll discuss what those letters mean or those directions mean. So here's an example on the right, moving right now, of the backward torsion, and now on the left the forward torsion is occurring. And you can see in both cases, as they reach their rotation around that axis, they're both facing to the right. Looks like one's looking up a little bit and the other's looking down a little bit, but both are facing to the right. So in the case of the forward torsion, this would be a right facing sacrum on a right oblique axis, because we have, here's the right side, superior pole of the axis for the oblique axis. In this case here, we have a backward torsion. You can see this is able to move posterior. And again, the sacrum is still looking to the right, but it is occurring around a left axis. So this is a right on left torsion, which would be a posterior or backward torsion. So again, what the letters represent, the first letter is the direction of rotation. The second letter names the axis. So we're talking about first where the sacrum is facing. That we will determine by looking at what the sacral sulci and ILAs are doing. As far as determining the axis, which will be right or left oblique, that will be opposite the positive seated flexion test. So we'll see a couple of examples of this in a moment. So when we look at these different diagnostic steps, again, we'll start with the seated flexion test, and it will tell you, for one, which side is dysfunctional, and two, which side the axis is on. So a positive seated flexion test on the right means that the dysfunction is on the right side of the sacrum, and it is occurring, if it is a torsion, it is occurring on a left oblique axis. As we look at the landmarks then, in a torsion, we will expect to find a deep sacral sulcus and prominent ILA on opposite sides of the sacrum. So that's important to remember. That is the characteristic finding of a torsion. If they're on the same side, then you're talking about a unilateral dysfunction. And then the spring test we will use to determine whether the sacrum is able to move anterior or not. If it can move anterior, a negative spring test, then you'll know that this is a forward torsion. If the sacral base cannot move anterior, so there is no spring, then that's a positive spring test and it is a backward torsion. Alright, so let's look at forward torsion specifically. So again, the seated flexion test is positive on the dysfunctional side, and in a forward torsion that will be the deep sacral sulcus, and we know that the oblique axis will be on the opposite side of the seated flexion test. In the case of a forward torsion, again the deep sacral sulcus and posterior ILA will be on the opposite side of the sacrum, so again that tells you it's a torsion and not a unilateral dysfunction. The lumbar spine is either going to be neutral or will tend to be extended because the base of the sacrum is going anterior. So the position of L5 can give you some information. The spring test will be negative because there is spring. The base of the sacrum can move anterior. So the diagnosis will either be right on right or left on left, depending on which side was the positive seated flexion test and which sacral sulcus was deep. So this would be an example of a right on right. Once again, we see the right oblique axis. The upper pole here is on the right, and as the sacrum moves, it rotates to face the right side. So if we look at this statically, right on right, you'll have a seated flexion test that's positive on the left. So the dysfunction is here on the left side. Because it's a positive left seated flexion, the axis is a right oblique axis. So that's where the rotation is. That's the axis around which the rotation is occurring. We'll have a deep sacral sulcus on the left, which is the dysfunctional side, and as is characteristic of torsions, the ILA on the opposite side will be prominent. So you'll feel this more inferior and posterior than the right ILA. And the spring test will be negative because the base of the sacrum is able to move anterior. Now, as the base of the sacrum rotates around this axis and turns to the right, L5 is going to rotate to the left, and the lumbar spine will compensate by side bending to the right. So that's what the whole picture looks like in a right on right. Now if we look at a left on left, exactly the same principles, but everything's reversed. So here we have our left oblique axis, and as you can see, the right sacral base is moving anterior so that the sacrum is facing to the left, just like a spinal segment. And if we look at that statically, seated flexion test on the right tells us that we have dysfunction on the right side of the sacrum with the left oblique axis, right? We'll have a right deep sulcus and a left prominent ILA. Again, they're opposite sides because it's a torsion. The spring test, again, will be negative because this is a forward torsion. The base of the sacrum can still move anterior. And again, as this is deep and can move anterior, the sacrum faces toward the left, rotates toward the left. L5 is going to rotate to the right, and the lumbar spine will side bend to the left. Now, let's look at backward torsions. So here, again, the seated flexion test is positive on the dysfunctional side, but this time that's going to be shallow rather than deep. Again, the oblique axis will be opposite the seated flexion. Sacral sulcus and ILA, again, are deep and prominent respectively on opposite sides. That's always the case for torsions. The lumbar spine now is either neutral or may tend to be more in a flexed position because the sacral base is stuck posterior on one side, so the lumbar spine will be flexed. Now, when we look at the spring test, because the sacral base is stuck posterior, there is no spring felt, so it is a positive spring test as opposed to the negative spring test in the forward torsions. The sacral base can move posterior but cannot move anterior. So our diagnoses here are going to be right on left or left on right. Again, this is the direction that the sacral base faces, and the second letter is the axis on which the rotation is occurring. So right rotation on left axis, left rotation on a right axis. So this would be a right on left, left oblique axis, and the sacrum is turning to face the right. Okay? So the position of the sacrum may look just like a right on right. The sacrum is still facing right, but the difference here is the axis around which the motion is occurring. Okay? So the shallow side is the side that is dysfunctional, and that represents extension. So now, where we're going to be noting deep sacral sulci, the deep sulcus will be on the same side as the axis, whereas it was opposite in the forward torsions. And again, the spring test will be positive because there is no spring at the lumbosacral junction. So if we look at a right on left, we saw that motion just a moment ago. Seated flexion test is positive on the right. So the dysfunction is on the right-hand side. This is going to be shallow, however. We generally mark our deep sacral sulcus as the landmark that we track. So now the deep sacral sulcus is going to be over here. Positive right seated flexion means a left oblique axis. So we'll have a deep left sulcus, prominent right ILA. Again, they're opposite, so that's consistent with the torsion. And the spring test is going to be positive because now we have this side of the sacral base on the right stuck posterior, and when you try to push it anterior, it won't go. So there's no spring. And then as this is looking, the sacrum is turning, rotating to face right, L5 is going to rotate to the left, and the lumbar spine will side bend to the right. And then if we look at we don't get the action here, but the left on right, we have a right oblique axis here, and the left side of the sacrum would move posterior, pull back posterior, so this would be turning to look to the left. So a left facing sacrum on a right oblique axis. So here we look at these findings again. Seated flexion test is positive on the left. The dysfunctional part is on the left. The axis is on the right. But because this is a backward torsion, our dysfunctional side is shallow. So our deep sacral sulcus is on the right. Prominent ILA on the left. Opposite sides, just like as torsions are. The spring test again is positive because this left base now is stuck posterior. And here are some of the comparisons between the forward and backward torsions. Now let's look at bilateral sacral dysfunction, because these also occur at the lumbosacral junction. Here the entire base of the sacrum is either going to be restricted in an anterior or posterior position, but there isn't asymmetry right to left necessarily. Again, remember that the sacrum and L5 will flex and extend in opposite directions. But when you look at the sulci and the ILAs, they appear even. Ultimately, you'll begin to recognize when both sulci feel deep or shallow relative to normal, and the ILAs feel prominent or less prominent relative to normal. But initially, when you're comparing them right to left, you won't notice the difference. So these dysfunctions, again, can be either flexed or extended dysfunctions. So with the bilateral sacral flexion, there's inferior motion down this portion of the SI joint and posterior motion down this portion, which results in the sacral base moving anterior and the apex moving posterior. In the bilateral dysfunctions, there is no rotation, so neither the sacrum nor L5 will be rotating. There will just be flexion and extension motion. Because the dysfunction is bilateral, the seated flexion test will be equivocal. And as I mentioned before, both sulci will seem deep and both ILAs will seem prominent. What this will look like is an equivocal finding, and you will have a negative spring test. So, again, looking at the static findings, your two sulci will be deep. So when you find PSIS on either side and you move just medially and drop into the sulcus on either side, you'll drop a lot deeper into them than you normally would. The ILAs will both be fairly prominent, more so than you would normally expect. And this motion is occurring around one of the transverse axes. The bilateral sacral extension will instead have anterior motion along this part of the SI joint and superior motion on this arm of the SI joint, resulting in posterior motion of the sacral base and anterior motion of the apex. Now, with the sacrum extended, the lumbar spine is flexed, and again, there's no rotation in either the sacrum or the lumbar spine due to this dysfunction. The seated flexion test again is equivocal, and instead of the sacral sulci being deep, they're both shallow, and the ILAs are non-prominent, and again, relatively even right to left. The spring test in this case, however, will be positive because you're not able to induce anterior motion across the base of the spine because it is stuck posterior. And again, here are the static findings. So bilateral flexion and extension compared here, some of the similarities and differences. Now, unilateral dysfunction can seem to get a little more complicated and seems a little less intuitive sometimes. But essentially what is happening, this now is a dysfunction at the SI joint. And really what's happening is a superior or inferior shear of the sacrum relative to the innominate or the ilium. And as you saw before, if we move the sacrum inferior or superior because of the shape of the SI joint, it will shift the base and the apex in opposite directions, anterior and posterior. Because this is happening on one side, however, it does produce some rotation of the sacrum, but because the dysfunction now is at the SI joint, L5 and the sacrum are going to rotate in the same direction. So that can be, again, one more clue to help you differentiate a torsion from a unilateral dysfunction. You will again find asymmetry in the depth of the sulci and the prominence of the ILAs, but in this case, as I mentioned before, we typically mark the deep sulcus and the prominent ILA, and these will occur on the same side. And this, again, is generally referred to as flexed or extended dysfunction. So we've seen this diagram before with the inferior motion down this vertical arm and posterior motion down the horizontal arm of the SI joint when we're talking about flexion motion or inferior shear of the sacrum. So it would essentially summate to a motion like in this direction going inferior. And we see the sacral base move anterior, which would produce a deep sulcus here, and the apex move posterior, which would produce a prominent ILA. But again, that will happen on the same side of the sacrum. And in the case of a unilateral flexion, there will be more tendency for the lumbar spine to be slightly extended. And in a unilateral sacral flexion, again, because this is an anterior dysfunction or flexion dysfunction, the spring test is negative because it is possible to move the sacral base anterior with this kind of dysfunction. And the seated flexion test will be positive on the side that is dysfunctional. So here we have the left sacral sulcus is deep, the left ILA is prominent. This is occurring around a transverse axis, and the seated flexion test is going to be positive on the left side. So this PSIS will move first and or farther than the right during the seated flexion test. And again, if we just remind ourselves of this image, the sacrum, as we put an inferior shear through the sacrum and through the SI joint, it will result in shift inferior here and posterior here, resulting in this anterior or flexed position of the sacral base. And that's how this occurs on one side but not the other. Unilateral extension, the spine is more likely to be in flexion because the sacral base is extended. Again, L5 is going to rotate in the same direction as the sacrum because this is primarily an SI joint dysfunction, not a lumbosacral dysfunction. The seated flexion test is positive on the side of the dysfunction. The palpatory findings on the dysfunctional side will be a shallow sulcus and a non-prominent ILA, although we will usually note the deep sulcus and prominent ILA on the opposite side. So when you find that, it could be a unilateral flexion on that side or extension on the other, and that's where you'll use the seated flexion test and the spring test to help you determine A, which side the dysfunction is on, and B, whether the dysfunction is anterior or posterior. So as this is a posterior or extended dysfunction, the spring test in this case will be positive. So here we have the seated flexion test positive on the right side, and the star now represents the dysfunctional side, which is shallow, the sulcus. But again, we typically note the deep sulcus and prominent ILA. So this circle is not exactly over the sulcus. It should be shifted over here a little bit. But this would be the deep sulcus and the prominent ILA. So again, you know, because they're on the same side, that this is a unilateral dysfunction. And then with a positive seated flexion test on the right, it tells you that the right side is dysfunctional. And with a positive spring test, it tells you that something is posterior at the sacral base. If this is deep, then this must be posterior. So it will help you determine that this is in fact the dysfunctional side, even though we tend to mark things based on the deep sulcus and prominent ILA. So here's again a comparison between the unilateral flexion and extension dysfunctions. All right, so we'll run through, there are a number of slides here that you can use to practice, and we're just about finished here. And we'll run through this with a bit of a system to help you dig all this apart. So if we look at this, we have a positive seated flexion test on the left. So that tells us where the dysfunction is, and if this is a torsion, it'll tell us where the axis is as well. We look at our palpatory landmarks, and we have a deep sacral sulcus on the left and a prominent or posterior ILA on the right. So right there, because these landmarks are on opposite sides, we know we've got a torsion. The spring test is negative, so we know this is a forward or anterior dysfunction. All right? And we know that because the positive seated flexion test is on the left, we're talking about we've got a torsion, so we've got an oblique axis, and it's got to be a right axis. So now let's look at how that would break down. So here's our left positive seated flexion test. That means our axis is going to be over on the right side. Dysfunction is going to be on the left. And if we look at our landmarks, we've got a deep sacral sulcus on the left, a prominent ILA on the right. So again, opposite sides on the landmarks means that we're looking at a torsion. We know the side of the axis because of where the seated flexion test is positive here on the left. And then the spring test is negative. So we know that the base of the sacrum can move anterior. So if the left side of the sacrum is deep, it means it's facing to the right. So it is a right-facing sacrum on a right oblique axis, or a right-on-right dysfunction. Okay? Now, I would just suggest to you guys, point out that you can actually take away any piece of information here and still, with only two of them, be able to get the answer. So if you didn't know the spring test, but you knew the deep sulcus and prominent ILA and the seated flexion test, you can tell A, it's a torsion because the landmarks are opposite sides, and you can tell the axis by the seated flexion test. So if you know that you have something deep on the left and a right axis, if it's deep on the left, it has to be facing right. So you know it's right, and you know you have a right axis, so it's a right on right. If you take away the two landmarks here, but you have a positive seated flexion test, so you know it's a right oblique axis, and you have a negative spring test, so you know something can move anterior, then you know that this is a forward torsion, so it has to be a right on right torsion. If all you have is these two landmarks, you've got a deep sulcus on the left, prominent ILA on the right, and a negative spring test, then you know that this side is able, first of all, you know it's a torsion because these are opposite, and you know that this side is able to move anterior. So you would be able to determine that it is a forward torsion, and it is facing right, therefore it is right on right. Okay? So you can piece together the final diagnosis with only two of these three bits of information, and then when you have all three, it just makes it that much easier. So here again we can see this is a right on right torsion. So you can go through the rest of these slides, pausing the presentation in order to try to piece it together and see how you do with the diagnosis. Thank you very much. Always be aware when you're talking to your patients of any mechanism of injury that might suggest a sacral injury. Thank you and good luck.